Thank you, and good evening, everybody, and welcome. I'm thrilled to be here with you this evening after a long day in practice, I'm sure, for all of us. And I really am I'm happy to share some of the information I've got regarding anterior composites. So about me, just briefly, I taught at Pacific for 30 years and retired fully in 2021 after a great career there, and to pursue and continue in my private practice, where I practice with my brother and my father. My father passed in 2018, which really realigned my career for me. I do a lot with product evaluation, bringing industry products to market, helping them position products, and looking at the ways we can get their products to streamline and maybe improve them. In addition to that, as was mentioned by Lisa, I am a member of Catapult Education Speaker Bureau and on the board of directors. I have a family, and we spend a lot of our free time up in Sonoma, California. Tonight's program is being sponsored by Ultradent. You need to know that Ultradent has paid an educational grant to Catapult for me to host this program for you. With that said, everything I show you tonight, any product that I use from Ultradent, is a product that I use in practice. It's something I do routinely, so I'm not going to show you something I'm not using currently or techniques that I don't employ at this very moment. So with that said, I want to get into just an overview of what we're going to talk about. I'm going to talk about some of understanding how the modern materials and techniques fit into your clinical practice, how you might implement some of the things we're talking about, how to place restorations not only efficiently, but with beautiful clinical results. And then finally, we'll talk about finishing and polishing protocols and placement protocols that really enhance the aesthetics of anterior bonding cases. So I'll do that through example of a few clinical cases. Now, I'm going to start with a fairly simple case, but it's something each and every one of us does on a routine basis. When you look at this patient, the first thing I hope you recognize is they have fairly opaque teeth, and this is not atypical in an individual in that middle life phase of our existence. They've chipped the incisal edge on tooth number 8, and that incisal edge has been repaired numerous times. And they keep reporting it as debonded. Now, we can see very flat occlusion across the anterior, and I would suspect this patient has some habits of parafunctional behavior that under force can weaken our bonds. So our goal here is twofold. Our goal is to, number one, get the restoration to adhere and to stay into place, and number two, make it blend. Now, the second observation I want you to make when you look at this is that small chip is in an area of the tooth that tends to be fairly translucent in most individuals, but in this case, not as translucent as you might normally see. When I look at a case like this, the first thing I think about is what is the shade situation. So I have a recipe that I work with using Mosaic Composite from Ultradent, and it's pretty simple. I divide anterior teeth, really into 3 types: lighter shades, medium shades, and darker shades. When I'm dealing with the darker shades, which this is, I generally tend to use a body shade like an A2 or an A3, and then I use an enamel shade, and in this case, I used what was called enamel yellow. Now, the neat thing about Ultradent's Mosaic Composite is it comes in different enamel shades, but I use enamel white, which is the lighter shade, for young teeth. For those light shades, I may use enamel neutral, and I'll show you a clinical case using that. For those mid-range shades, the A2s. And then when I get up into the A3s and A4s, I'll use that enamel yellow over my dentin shade. So to make this disappear, the first thing we have to recognize is if we only use an enamel shade here, this restoration will actually be far too translucent. The second thing we want to recognize is how we manage the bevel. And in this case, I've employed what's called an irregular bevel, or some call it a starburst bevel. But you can see this beveling pattern kind of starburst off of this restoration, and that will help break up the light. So I'm going to place, very simply, an enamel shade over a dentin shade. And in this case, I selected a dentin A3 with an overlay in this whole area of enamel yellow. Very simple recipe for these teeth that you kind of learn as you go through using this product, how simple it can actually be to get a chameleon effect. Now, when it's all said and done and polished, you can see it blends in quite nicely. And the reason we got that result is that irregular bevel. That irregular bevel is essential for hiding the restoration. The reason we got the right amount of translucency is that overlay of the dentin shade with the enamel shade on top of it. And that enamel yellow blends into these kind of yellow-hued enamel shades very, very well in these older individuals. So that's kind of a recipe I like to use. Now, with that said, I want to talk a little bit about the materials and the bonding protocols employed to make sure that this is actually a success for us. I think it's important to recognize that adhesives have changed. And in fact, I hope you leave this evening's program with some good clinical tips, but also the concept of being what I would call a smart bonder. Now, traditionally, I'll admit, for years, I was what you would call a etch and rinse doctor. I used a 5th generation adhesive like OptiBond Solo Plus for years and would etch all aspects of tooth structure, whether it be dentin and enamel. But after years of experimentation with these different adhesives, I finally recognized that my bonds to dentin sometimes failed. Why did they fail? They failed really because these systems were designed and worked appropriately or most efficiently on enamel restorations. And while they worked okay on dentin restorations, they weren't really designed with dentin in mind. When we look at all the literature on self-etchers, we have to recognize that self-etchers actually perform better on dentin. But if I use a self-etcher alone and I'm on an anterior tooth, I'm struggling because now I've sacrificed my enamel bevel for a dentin bevel. So what I hope you employ is a system that allows you versatility. And I really think you can find those in many self-etching systems. See, the beauty of self-etchers is the acid is strong enough to etch the dentin quite well. But when you need a stronger acid on enamel, you can implement the use of a total etch technique. So why self-etchers? It really gets down to matrix metalloproteins on dentin. And these self-etchers do, in fact, perform better. Excuse me, I'm fighting a cold. On dentin surfaces. Lots of research on this. I'm not going to bore you with Mazzoni, Tay, Pashley, Carrillo, you name it. They all really examine the use of self-etchers on dentin. And they showed a couple of things. First of all, they showed that etching with a self-etcher is kinder to dentin, establishes a higher bond. It doesn't activate as much MMPs. And they also showed in several studies that chlorhexidine was a pretty good MMP inhibitor. And that MMP is the thing that breaks down our dentin bond. So with these 6 generations, we have some versatility that's built into the system. Why? Well, we can etch, if we choose, with the self-etching adhesive and primers, or we can introduce a 5th generation technique. So when I look at, say, Ultradent's product, Peak Universal Bond, Peak Universal Bond is the bonding agent for any etching technique. So what I think about when I turn to Ultradent for my bonding is that I have Ultra Etch, a phosphoric acid-based etchant that I can use on enamel quite efficiently, or if I wanted to total etch, I could choose to do that. And the Peak Universal Bond remains the same. I also have Peak SE, which is their self-etching component, and I can etch my dentin with that. And I could do self-etching alone. But if I want to employ both of these etchants and move into what's called a selective etching technique, I can do that. Now, it's important to recognize that your bond strengths with any system are maximized by following instructions. These are the instructions for Peak SE, Peak Universal Bond. And when you really add it up, it equates to about 60 seconds to get a very, very strong bond. That's time I'm well worth investing on an anterior restoration, which you have to recognize is always under stress, wants to give away. So it's important that we really look at a bonding system that gives us the versatility. I can total etch, I can self etch, I can combine these two for selective etching under various clinical situations. And we do that using very specific timing. Now, I want to point out that when you're applying either an etchant, a gel etchant, phosphoric acid, or a self-etchant, generally speaking, there's a prescribed period of time that you need that product to be present on the tooth. With the Peak system, it's 20 seconds for either. And if you do selective etching, it would be a total of 40 seconds, 20 for one, 20 for the other. Then you apply your adhesive. And that adhesive is applied after you've air thinned your self-etchant or rinsed off your total etchant. And then you air thin for 10 seconds. And it's that air thinning that actually gets you your high bond strength. Believe it or not, that 10 seconds of air thinning is absolutely critical to establish a very high bond. So I think it's really important that we recognize that that's the critical step here. In addition to that, light curing for 10 seconds, of course, gets the job done. So I can use total etch with any generation, 4th, 5th, 6th, 7th, or 8th. Self-etching really with 6th, 7th, and 8th, if I want to be self-etching alone, and selective etching with a 6th or 8th. So if I say, okay, I look at this chart and say, well, I can't selective etch with a 4th or 5th. If I want a 4th or 5th, I'm going to have a 6th or 7th or 8th. And I look at the 6th as those systems that provide a lot of versatility. And the reason I've really moved towards a self-etching system with the capability of total etching or selective etching when I choose to is that it allows me to do any etching technique given the clinical situation. So I've moved away from this total etch concept to a smart bonding concept. I look at the clinical situation, and in the case when I'm on enamel exclusively, like the case I just showed you, that would have been a total etch case. Simply my ultra etch with my Peak universal bond. However, if it was fractured into the dentin, I might have considered selective etching. So it gives me the versatility of doing really all these different systems and bonding techniques. So here's kind of a little schematic. If I wanted to total etch, traditionally I'd PQ1 from Ultradent, but they've really replaced that with a Peak universal bond as that universal bonding agent across all of the etching techniques, whether it be self-etching or total etching. And this allows me to do really the best of both worlds. Now, I know in the marketplace, there's a lot of push towards simplicity in bonding agents and fewer steps. But I need to let you know that every time you eliminate a step from your adhesive system, you're generally sacrificing bond strength. So I look at these systems and say, okay, this is the most critical aspect of the restoration for longevity. Do I really want to save 10 seconds at that phase of the procedure? I can show you we're going to save 10 seconds in a much more efficient way and probably a wiser way than on your adhesives. So I really live in this area. Now, a lot of what I do on anterior restorations does in fact utilize a diagnostic wax up and an incisal edge putty. And that's for patients who have fractured their teeth and really come to me for the best of the best. They want a beautiful restoration that they can chew with and not worry about, and they want it to blend in seamlessly. When that's the case, I'm going to employ the use of a putty. You can do this freehand. The problem with freehand is inevitably you can't control the volume of the composite you're placing initially, especially at the incisal edge. So we tend to overfill, and initially as we carve these back, the restoration might look pretty good, but if we haven't managed the overall thickness of the material, then we run into a trouble aesthetically. So I do employ a putty matrix, and I'll get into that. I want to briefly mention some of the composites. Ultradent's just launched Transcend, which is kind of a follow-up to Mosaic. Mosaic is the composite I've been using for quite some time. In addition to that, you need to select a flowable. You will use a flowable in some cases, and you want a flowable to have a couple of things. First of all, you want a flowable that has enough radiopacity to be evident on an X-ray. And keep in mind that flowables are all over the map, from maybe a low of 150 to a high of 320. And the higher that radiopacity, the more radiolucent it appears on an X-ray. So it's really critical that we look for flowables that have radiolucency that makes them visible on an X-rays. You'd be surprised at some products that come from overseas may be quite inexpensive, but they lack radiopacity. To build in radiopacity does cost companies money, and that's important to recognize. Now, lots of studies have been done on flowables. You can read these later offline, but they talked a lot about micro leakage and that. And what they've shown pretty clearly is that the use of a small amount of flowable in many clinical situations does in fact lead to better adaptation. Doesn't mean you do the whole restoration in flowable, because quite frankly, under high stress areas, they may not be strong enough to withstand those forces. But it does mean that you can use them. Now, when you talk about radiopacity, I would really look for a number of about at least 200 on the aluminum scale. 200 and higher will get you more radiopaque than enamel. Enamel's right around 180, dentin's right around 150. When you get right over the pulp, that radiolucency is about 100. So it's important to recognize that if you can get something with the radiopacity figure of 200 or higher, when you place it on enamel, it will be evident in a radiograph, which is makes our diagnosis very, very simple. Here's an example of radiopacity and two flowables. You can see Premise Flow here and Revolution Flow, two older flowables still on the market, and some overlying composites. We need to recognize that opacities come in different shapes and forms. When I'm trying to select radiopacity, I look for products with high radiopacity so that regardless of where I do a restoration, when I restore a tooth, I can see it. Now, when you look at this radiograph, you can see on this lower premolar here, lower first premolar, that is a very large restoration, but not very opaque. This is a very small restoration, but quite opaque. This one actually has higher radiopacity. Well, in this clinical case, I replaced this DO on tooth number 13. And when it's all said and done, I employed high radiopacity composite material so that you can see it. Now, believe it or not, there is a flowable under here as well, and it has matched radiopacity to the product that I overlaid with. So keep in mind, you want to look for a flowable that, number one, handles well for you, does what you need it to, and number two, has enough radiopacity to not look like a void on your radiograph. So keep that in mind as you search for a flowable. And here's an example. Premise is being used as a control here, and these are 8 different flowables, all with different radiopacities. Some of them are in fact higher than a Premise, which is about 300 on the aluminum scale, and others, A, D, G, and even B to some degree, are less radiopaque than the overlying composite. So know your radiopacity figures, ask your companies what their numbers are. When you look at Mosaic, its radiopacity is right around 200, and that's very close to Ultradent's flowable. So when you use these two products in conjunction with each other, they have matched radiopacity. Here is the shading of Mosaic, and as we go through a few more clinical cases, I'll show you how I do that. But basically, I look down here at all these dentin shades. You don't need all of them. You can hand select a few. And my favorite enamel shades are enamel white for young teeth, enamel neutral for middle-aged teeth, enamel yellow for my geriatric patients. I can match almost any tooth with those 3 enamel shades and about 4 different dentin shades. Most of them, in fact, are A shades. And I'll keep a supply of B1 as well for the super white teeth. So pretty simple formulation. This material has very high strength, both flexural strength and compressive strength, very high compared to many other composites in the market. And it polishes beautifully. So I'm going to show you another clinical case. We'll kind of get into this and how we manage this just a bit. This is some of my thoughts on a class 4 fracture. First of all, let's face it, we've all done these and we've tried to freehand them and it's going pretty well until we get to that final contouring, and then suddenly the restoration appears as different than the rest of the tooth. And I'll give you some tips on why that happens. But most of the time it happens not in material selection per se, but in preparation management. So we're going to spend a little time here. But I want you to employ what's called an irregular bevel, not a standard bevel. And that irregular bevel should be quite spasmodic. It must vary in depth and length. So not only depth into the tooth, but length up the axial surfaces of the teeth. So when you look at a class 4 fracture, and this is just a type it on, obviously demonstrating this. When someone fractures their teeth, it tends to be a very clean line. So we've been taught for years by Swanson that a standard bevel right along here at 45 degrees would do two things. It would help to hide your material and increase surface area to bond, both of which are true. However, sometimes you'd put your bevel on here and you'd restore this and you'd see it. And you'd see it based on two things. First of all, it could be based on this irregular bevel not being quite irregular enough. So when I do these, I make them quite irregular, that kind of starburst pattern. But where you're actually likely to see the restorations more is if you fail to break up this fracture line. If you don't modify that and just do the irregular bevel, this restoration will actually be visible once you've contoured it to the correct contour. So what I will do is I will break up the fracture line along that fracture point. What that does is scatter light within the restoration, and it helps blend your material. So this is incredibly important to deliver these restorations that really, really look quite good. Okay, this is my son, Justin, who fractured his 2 front teeth while falling in a playground, and I've got to restore those. Justin's visually impaired, so he's not really concerned with how his teeth look, other than he wants to be appealing to the opposite sex. So he came to me at age 24 after living these for many years. He's like, "Dad, I want you to fix my teeth." I'm like, "Absolutely, son, I'll do it." So here is his fractured teeth. They're very clean fractures. And this is a tough area to bond to. Now, the first thing I want you to look at is the reflective properties off his teeth. And what you notice is, because he's quite young, his teeth still have these vertical invaginations running up and down the facial aspect. And really, when we look at the second reason for these not blending, what I see too often in anterior composites is the anterior composites have been grossly over polished or over finished. So I'll work to maintain that anatomy. And I have to be very careful how I manage these little fractures. So when we look at this case, the first thing I'll do is a diagnostic wax up. That diagnostic wax up clues me into the amount of lost tooth structure. Okay. And I will come in here and overlay the facial aspect with my wax, create that an ideal incisal edge, and then create my incisal edge putty. When I load this putty, I will actually place a mylar strip between 8 and 9, and I'll load all of the lingual aspect of the putty with my enamel shade. Now, if we go back and look at Justin's color, I hope you recognize that Justin has fairly light teeth. While they may not be B1, they are an A1. So his recipe, I knew, was going to be A1 enamel. And because that's our lighter shade, I'm going to overlay that with the enamel, a lighter enamel shade. So it will be either enamel neutral or enamel white. But in this case, I selected enamel white. So we're going to go ahead and overlay that. Now, here are the preparations, and I want to go over this with you. The first thing I do is come in here and just create this irregular bevel across the incisal edge. And I want to create that irregular bevel, and I want it to vary in height and depth. That's critical to make these absolutely blend in. The second thing I've done, and I want you to look critically, is I've come in here with just a little diamond and scored this incisal edge ever so slightly. What that does is help me blend the material so that it will reflect the light in a completely different manner. Those two parts are incredibly critical. In addition to that, because he doesn't really have a lot of translucency, I want to make sure to provide a lingual portion that is actually a dentin shade to provide the opacity I need, and I want to control its volume. Well, the only way I can control the volume is by using that putty. Now, here's the finished restorations, and I hope you recognize that we've maintained the luster of the teeth. We haven't modified things, and these blend in perfectly. You can't see where they are. And that's by the use of a polishing system that is not a disc. Do not put a disc onto the facial aspect of these teeth. If you do so, you're going to flatten the entire surface. You're going to take out all of his natural irregularities that provide that bounce of light in different directions. And you're going to make these look terrible. But rather, I turn to a product called a Jiffy Natural, which I'll show you in just a little bit. So how did I do that? I used the Mosaic 2 shades only, that enamel white over an A1 as my recipe. And I used a composite warmer. And for me, composite warmers do a tremendous amount to enhance the pliability of my composites. So with Mosaic being a relatively stiff composite, I'd like to use a composite warmer. Now, I'm not going to bore you with a lot of studies on composite warmers, but I can say this. The literature is really well established that those of us employing composite warmers, if we do so in an efficient way, will lead to a restoration that has a greater depth of cure than a room temperature composite, has higher monomer conversion, higher overall compressive strength, and less marginal leakage, which are all good things. So I think a composite is cheese, nothing more than cheese. Now, each of us would have our personal preference at room temperature, what we'd like to place. Honestly, I'd like my cheese to be somewhere between a Gouda at room temperature and maybe a Brie at room temperature. I don't want something as soft as Philly cream cheese, but I definitely don't want something as hard as Parmesan or Reggiano or even a hard cheddar. Too hard, too crumbly. So what I think about most composites is they are very highly filled. Mosaic is a great example. But as being highly filled, they tend to be very rigid. They tend to behave like that cheddar or the Parmesan or Reggiano. But if I take and use a composite warmer, I can soften the cheese and get a much better result. So when you look at this science, Bosch originally showed the use of the first really warming indications were on early restorations cemented with a hybrid composite. Castro and Il Caroshi showed in their studies that you had greater depth of cure and monomer conversion when a composite was heated. And these are simple studies that very clearly showed that. In addition, Frays and Castro showed that you had decreased number of voids in restorations placed under a warm situation compared to a room temperature situation. Why? The composites just behaved a little differently and made it easier for clinicians to place these things. Nothing frustrates me more than an anterior composite that I've worked so hard to place, yet it's got a void. What I noticed with these very rigid composites is they were hard to manipulate, hard to get into my putties, hard to prevent voids. But as soon as I warmed them up, the number of voids present in these composites just went way, way down. You also see a lot of information on the overall water absorption and solubility when you compare room temperature with a composite that's been placed under heat. So with that said, Carlos Munoz showed in his study on depth of cure, I would highly recommend you all consider the use of a composite warming device. This is one from Voco that's quite effective. This is another one they employ. This is BioClear's warmer. The one I actually use is from Adent, and it uses 3 temperature settings. But really for warming composite, I set that at 155 degrees. I can load my gun here with my selected first shade, usually the Denton shade in A1. And then I can put my enamel shades in here to be warmed and ready to go for overlaying. So I really strongly suggest you look at the employment of a composite warmer. Now, I want to talk a little bit about instrumentation. Instrumentation is essential for creating these lifelike results. And one thing you want to consider is the use of a carbide burr. I like to use carbide burrs. My favorite composite instruments are from Clinician's Choice called the Ronald Jordan. The REJ10 is my kind of go-to anterior restoration product. Microcopy makes a great disposable carbide that is really effective. Now, the reason I implement composites and finished composites with carbides is they tend to leave the surface smoother than a diamond. While they may not be as efficient in cutting, they will leave it smoother. And I can create my nice irregular surface that is easy to polish. Now, the polish I show you on my son's case was established with Jiffy Naturals. Jiffy Naturals are a great polishing system from Ultradent. It's a 2-step. Why do I like these compared to, say, a sandpaper disc or something? The reason I do is these designs are anatomy sparing. I can use very light pressure and bounce on and off the tooth and not obliterate the natural anatomy I've created while still establishing a high luster, as opposed to a disc that in order to polish it must cut. And as it cuts, it flattens. So using a carbide to create your anatomy and then polishing with the Jiffy Natural system, yellow first, followed by white, creates these beautiful luster in really just 2 simple little steps. So I really encourage you to look at these systems. I want to talk briefly about class 5s and give you some thoughts on class 5s. Now, when we talk about adhesive systems in class 4s, generally speaking, I would employ either a total etch or a selective etch. But on a class 5, if you're on root structure alone and there is no enamel involved, that's where self-etching makes the most sense. So then I'd turn to my 6th generation and say, okay, forget the blue gel. I don't need that. I just need the self-etching, the PEEK SE component, married with PEEK universal bond. And then there are the class 5 situations where you have a little of both. You're on dentin in the root area, obviously, but you're also on 2 structure that has enamel towards the occlusal portion. And that's where I employ then a selective etching technique. So I want to show you self-etching as opposed to selective etching with a few clinical cases for class 5s. You want to bevel again in a regular fashion, bevel on the enamel, no bevel on the dentin, and only consider retention features if you absolutely need them. But generally speaking, I avoid cutting and retention at this phase of my bonding career. So in a class 5, generally speaking, we were taught that 45-degree bevel, about a millimeter to a half a millimeter or so, and that would increase surface area and help to create a chameleon effect. I've completely gone away from that standard bevel to an irregular bevel on all class 4s, all class 5s on anterior teeth. This irregular bevel is the game changer. It will allow the materials to blend and really help with the chameleon effect you're trying to establish. So it should vary again in height and depth, just like I showed you with our previous clinical case. So if I'm going to do selective etching, the selective etching would employ an etch on the enamel first, and we'd apply our blue gel on the enamel. So here's a clinical case where I'm bonding these restorations. I'm going to place a cord first, and following that cord, I'll do my irregular bevels. Then I micro etch the teeth, get my irregular bevels in place, go through our bonding protocol of these products, and then we go ahead and restore these with a flowable. Why a flowable? Well, a flowable in a class 5 situation, especially on anterior teeth where they're getting a lot of facial stresses, will allow them to flex. So I like a flowable for this. Remember, you want a radiopaque flowable, and place those flowables, bring them into your irregular bevels with nothing more than an explorer, finish them back with a carbide finishing burr, and then polish them. This is the old Jiffy system using points, but the results are fantastic when you employ those irregular bevels. I use retraction cord routinely for these. Why? Because I want to expose that little area of the margin. Generally speaking, if you've got a lot of recession in anterior teeth, keep in mind that that can be a thin gingival biotype situation. So you want to lean towards those 000 or 00 cords. Don't be up here trying to put a 3 cord in a tooth with a thin gingival biotype. You'll just cause further recession. But you can sneak these super tiny cords in very easily that control circular fluid and make that bonding process quite easy. If you've got any bleeding, employ a little viscostat to do that. Now, when we talk about selective etching, again, I'm going to give you an example. Here I've placed the cord. Now I'm going to go ahead and etch the enamel. Then we come in with a peak universal and etch the dentin. Don't worry if you get this on the enamel. It does not modify that bond you established or the etch you've established. It's not going to make it worse, and it's not going to be deleterious. So then we go ahead and apply our bonding agent, air thin that for 10 seconds, and light cure. And restore these very simply with that. Now, we can finish those back with a 12 fluted carbide and polish them up, and we're good to go. So on these anterior teeth, I think it's really important that we recognize a couple things. Now, this restoration on this cuspid was quite large. It popped out, it debonded after 30 years of service. How do I know that? It was in our charting. It was my dad's restoration. It was an old hybrid composite, but served the patient well. So when I went to restore this, there's an expectation of longevity. And I know I can get a high luster. But I placed an irregular bevel right here. Now, when I look at the restoration over here, I hope you recognize that this actually, the cervical area of this tooth is actually slightly lighter than the middle of the tooth. The patient did not see that. Of course, they're probably looking at this big old hook over here, but they did not see this. Why did they not see that? Because of that irregular bevel. That irregular bevel will blend these shades harmoniously. And it's critical that you employ that irregular bevel to get the job done. Before you show the patient, scrub this with a little viscostat, you'll be good to go. And it's that irregular bevel that really makes all the difference in the world. Okay. So with the time remaining, and we've just got a few more minutes, I encourage you, if you have any questions, to start typing them in the Q&A. I'm going to show you one more clinical case. And this is really the technique we've been talking about at work. This is a young individual who came to my practice as an individual going through the mixed dentition phase of life. He hadn't gone through ortho yet. A lot was going on. And he unfortunately took a baseball to the face, fracturing his maxillary lateral incisor and his mandibular two left lateral incisors. And I looked at this case and knew that with these smaller laterals that he would be going through ortho at some phase. He's still got posterior primary teeth. And I knew that I had to get him through to that phase in life. So we decided, working with the orthodontist, to create spaces for him and bond these temporarily, not knowing where these teeth would go. Now, the upper one broke off 1/3 of his lateral incisor, quite a bit. The lower tooth literally fractured off half of the incisor. This is incredibly hard to bond to. We've got a lot of exposed dentin. We're worried about pulpal necrosis. But for these, I selected to do, number one, a wax up. The wax up will allow me to control the shapes here. And I can control the shapes here. And doing that wax up allows me to show the parent and the child just how much tooth structure is present. So here's that wax up on the lateral incisor, wax up on the lowers, and we can see how much I'm going to be adding. And this is presentation wax. I like this wax because it very clearly demonstrates to the patient what they've lost. But this is 50% here. No pulpal exposure, but a vital tooth. And I've got to manage this. Now here I'm going to employ an irregular bevel, and we're going to go ahead and restore these. So I take my impression, and I'll use, in this case, because I had some diastemas, I'm going to use the putty interproximally to restore these. So I can do the same thing on the lower. Here, I'll put an incision with a mylar strip. Here, I'll use the putty actually to confine this. And we go ahead and use these putties to restore the lingual aspect. Now, this is, again, a very simple recipe of an enamel shade and a dentin shade. Here are my irregular bevels coming across here. Here's our irregular bevel coming across here. And we'll preload that. You can see our mylar strip here. This is my lingual dentin shade being placed, and I'll get that into place. And before you cure this, I'm going to come in here and tap this little area. Get that little void. Don't let that be. So you'll come in and you'll manipulate your instrument just a bit. Then we come in and we overlay with our enamel shade. We turn to the upper and we do the same thing. Here's that nice big irregular bevel across there. I've broken up the fracture line. We come in and we fill that first with our dentin shade, and then we come through, clear off any excess, making sure we don't get the dentin shade too far out to the facial. And we come in and overlay with that with the enamel shade. We've got to give his teeth time to rehydrate from all the finishing. And when it's said and done, we've got perfectly restored teeth. He's now ready to enter, as he leaves that mixed dentition phase, now in the phase where he's got just his erupting permanent teeth. He can go into ortho and get all of this corrected. And it's just a really nice workaround for this clinical situation. So we can see how well those blend in and how well they serve the patient. So that's just a simple technique using that wax up. All these spaces were measured on contralateral teeth. So that gets him through and gets him to adulthood. So with that said, I've left just enough time for some questions. I see I've got a couple of questions. So I encourage you to type in your questions. Follow me on Facebook or Instagram. I'm Marin Dentist on Instagram or Facebook, Marc Geissberger. This is my email address. If any of you want to reach out, post this program, feel free to do so. And I want to thank you for joining me. Let me go to this Q&A. So Michael has a question that's really how do they access recording? So Lisa, I'll leave that one up to you. George, what is the putty you used? In this case, I used a Kettenbox putty called Panasil. That's my kind of go-to putty in these clinical cases. And then what's the name of the wax and who's the supplier? So the wax is from Kerr, Belle de St. Clair, and it's called presentation wax, but it's a Kerr waxing or Kerr laboratory product. And I like it because that's really that opaque and it shows up well on a situation like that. Do you routinely, Terrence asked, do I routinely micro etch my preps? And the answer is yes. I've got my Danville micro etcher, and I am in a habit of routinely micro etching the preparations. I've found over the years that I just have far less debonding with that. So I think that's a very effective way of doing that. So that's Terrence, what I do on a routine basis. And it really does help, I feel, with the overall bond strength. So just to reiterate, the protocol would be prep the teeth, isolate the teeth, however you're going to do, micro etch your surfaces after you've prepped, and then go through your selected bonding protocols, whether that be self, total, or selective etch. But you can tell for most of these anterior, I'm either going to do a total etch or selective etching. It's unlikely that at the incisal edge I would ever employ a self-etch technique. Down on the root, sure, but not down in that area. Okay, so there's a couple more questions. Just bear with me. So do we have to worry about the retention for tooth number 22 in the last case with which presented? Well, of course we do. With that said, that tooth's prognosis probably is ultimately going to need a root canal at some point. But I'll tell you that clinical, that gentleman in the picture you saw, he was 12 years old. He is now 22 years old and finishing up college in New York. He's a good family friend. And those 3 restorations are still in place. We haven't touched them in 10 years. So I guess the answer is, yeah, we should worry about it, but it doesn't keep me up at night because it stayed bonded all this time. There's an anonymous attendee who said, well done, Mark. So thank you so much for that. And he says most cases comment aren't a function of bad bonding. Oh, sure, I think some cases are a case of bad bonding, but most cases you'll see are a combination of occlusal issues, protrusive issues, you name it. There's a lot of contributing things that go on, but yeah, I think there's a lot of multifactorial in these incisal edge cases. If you don't manage occlusion on an incisal edge case with direct resin bonding, you're going to have issues. It's less likely to be your bonding than occlusal issues. So thanks for that comment. So how to prevent a white line in an anterior restoration? That actually has to do with how you're managing your bevels. So I would really be aware of that when Dr. Zhang. So when you're looking at that, just watch your beveling. And that's the most likely cause of that. Also, if you're not doing proper adhesion, you can have the white line appear from contraction there. But generally speaking, if it comes in an area where you're cleaving enamel, and that enamel hasn't been well managed during the preparation phase. So I don't see any further questions. So with that said, I want to thank all of you for joining me this evening. I'm sorry for my hacking coughing spell earlier, but it seemed to have cleared up. So again, it was a pleasure being with you. I hope this was informative, and thanks, and be well.